We have a few minutes for our question and answer session before we have to move on to the next session. So, okay. So as we start this session, I have a question for Dr. Hoskoppal. How do you typically counsel your patients that have had repairs or procedures for their complex transposition anatomy if they desire a pregnancy?
Thanks for asking that. That's a great question. Is this on? It should be. I'll try this. This is better. Great question, Yvonne, because in the recent qualitative study we did, the patients do look at their pediatric cardiologist as the primary source of counseling for pregnancy and contraception. So this is important for all comers to understand, not just ACHD. That being said, in this particular population, it depends. Generally, they do tolerate pregnancy well, but things to take into consideration is lack of arrhythmia burden, normally functioning ventricles, and no more than moderate dysfunction of the biventricular outflow tracts, and then they generally tolerate pregnancy well. If you had to put them in a WHO classification risk category, I would put them in a classification 2, which is higher than regular general population, but pregnancy is certainly not contraindicated, but they do need follow-up throughout pregnancy.
Thank you. Erin, this question is for you. How long does it take you to typically prepare a family for this type of surgery when they come for their pre-surgery consultation?
I guess you can hear me now. No. Is it on? Okay. My voice is normally louder. So, it really does vary, but I find that they're in our clinics doing counseling, I guess, for close to an hour, if not an hour and a half. And I always say I take as much time as I need and the families need, and we're lucky that the way that our clinic is set up that we're able to do that. The financial people might not be happy about that, but we need to spend that time with the family. But I think knowing going into it, if we can get as much information before on how the family learns, what their different maybe roadblocks to learning or understanding are, it helps, and it helps us to tailor that discussion. But it's as long as they need, but I can tell you it probably doesn't take us longer than a good hour just for that education, especially when you're talking about something as complex as these repairs that we're doing.
Jackie, when a family comes in for their fetal consultation, how does you and your team approach this discussion, given the fact that the repairs there are multiple different types of repairs, depending on the complexity of the anatomy? How do you approach that, and so that the family understands?
Yeah, that's a great question, and I think it really speaks to the challenges with fetal cardiology in general, that oftentimes there's a lot of uncertainty with what we're counseling families about. We can be fairly confident about the anatomical diagnosis, but truly understanding how that physiology will change in the early postnatal period, and understanding which patients will need that urgent intervention in the first week of life compared to those who can wait longer for a more definitive repair is a big challenge. I think, like I said in my talk, we try and cover all our bases, but that then can be very overwhelming for families to hear about 3 different types of surgical possibilities that might happen. I think, like Erin talked a lot about, we try and read the room as best we can and really assess which families we can be more simplistic about. that we will have to wait till the postnatal echo to determine the exact anatomy and what repair is going to be best for that anatomy, that some babies will be sick after birth and require a balloon septostomy, but some won't be as sick, but will still likely need an early intervention, and be more simplistic about the fact that we will need to reroute the blood flow to make it a more correct anatomy. But that doesn't always 100% fix the problem. As opposed to those families who are more, we sense can get more of the nuances of it, and we can explain that there are certain technical differences with the surgeries, and that then imparts different risks for the lifespan for those, those certain repairs. It's a big challenge, and I don't think there's a perfect answer. But I do think that it's important to really assess how well a family is understanding. We also usually get the liberty of having multiple visits with a family during the pregnancy, and we try and bridge that gap from the fetal discussions with the family about what to expect in the early postnatal period as well as the lifespan, but explaining that they're going to be supported by a team in the ICU and our cardiology service and an outpatient cardiologist all along that lifespan. And like Erin mentioned, we also will provide support to our family from our neurodevelopment team, who does prenatal consults and behavioral health sort of support for families too, to really help them along that whole process.
And Jackie, too, to mention getting those families a visit with, like, coming to the surgery clinic and meeting the surgeons, meeting our social workers, touring the unit when the baby's going to be born.
Prenatally,
yes.
Yeah,
prenatally, where their baby's going to be. And I can remember, even when I was a bedside nurse, seeing, the dad in the room by themselves and moms at McGee, because where they deliver is far, it's far away.
Separate.
I mean, it's not that far, but
10-minute drive.
it's you can't. The mom can't walk there, and the moms have always said, when I knew, like, it wasn't as bad because I remembered seeing it. I knew where my baby was going to be. I think it's more stressful when they haven't done that, or it's an unknown diagnosis, obviously, when they're born. And I think it's the same thing when you look at preparing for a surgery, and a big thing is preparing. The unknowns are what's scary to these families, and if we can take that away at all, to me, that's what helps and aids in recovery and everything else that happens after.
One final question, Avihu. What are the typical lengths of CICU stays for these types of patients?
So, as I mentioned in my talk, the expectation really, in spite of the complexity of this operation, the expectation is that the course would be relatively short. And that's surprising, but it was surprising to me, actually. It's a very rare operation, and we are not, as intensivists, we don't see that a lot. So you expect, with a long cardiopulmonary bypass time, very complex operation, they would have very prolonged course. But with the right hands, surgical hands, that actually can be a relatively short course. And as I said, it's important to actually drive, push the leg on the gas to get them extubated as quickly as positive, and to de-escalate as soon as possible. So again, it's not a very common operation, and we don't have many patients to rely on as far as overall natural history and postoperative care, but this is the expectation.